Good morning, everyone. I'm Ava Kadiwada, one of the medicine chiefs this academic year, and welcome to our grand rounds this morning. Today, we'll be spending the hour with Dr. Al Kim, who is assistant professor of medicine in the Division of Rheumatology here at WashU in St. Louis. Dr. Kim founded and directs the Washington University Lupus Clinic, a multidisciplinary clinic that incorporates rheumatologists, dermatologists, and nephrologists in the care of patients with systemic lupus erythematous. The goal of the clinic is to enhance the quality of life of those living with lupus. The clinic provides state-of-the-art clinical care while engaging in research, both original and clinical trials, and enhancing community relationships. The clinic also engages with national lupus research networks. Dr. Kim is an investigator in the Lupus Clinical Investigator Network and Lupus Nephritis Trials Network. In addition, he runs a research group that focuses on translational and clinical questions surrounding human systemic lupus erythematous. Thank you so much, Dr. Kim, for joining us this morning for Medicine Grand Rounds.
Thank you so much for that introduction, and I welcome everyone to Medicine Grand Rounds today. Anytime you discuss COVID-19, it is so tricky because the field is so dynamic. And so it's with some trepidation I present the current perspective of that rheumatologists have about with COVID-19. And this trepidation really is largely because of the overwhelming rate of information. But not only that, the quality of the studies really leaves some, the quality isn't as good as some of the other fields. And this has become very challenging for the public to be able to interpret what's going on. And on top of that, also clinicians. So I think this has really increased the amount of confusion and misinformation regarding what COVID-19 actually does. So regardless, patients are clearly impacted by COVID-19. And so we have to be comfortable providing proper and actionable interpretations, but we also have to be able to learn how to pivot rapidly when we are wrong. So with that disclosure in mind, I humbly submit my own interpretation of the perspective of rheumatologists have regarding COVID-19, mostly regarding patient care. So these are my disclosures. None of them are relevant to this particular discussion. So I'm going to start off, as most COVID talks start off, by showing the Johns Hopkins University COVID-19 dashboard. This was obtained a little over an hour ago. This is incredibly frustrating to look at. Over 64 million cases have been confirmed, 1.5 million deaths globally, and the US leads in both categories. The frustration obviously stems from the proportion of this being preventable or attenuated if we had effective government leadership. But be that as it may, I do want to take the opportunity to offer my thanks to the WashU community. There's too much to list here, but generally speaking, leadership, the crisis management team, all the clinicians, particularly the hospitalists and intensivists, the nurses, house staff, medical students, researchers, because there was this swift and unified response that has been really impressive to observe from my own side. And so it'll certainly get worse before it gets better. And the next 3 or 4 months are going to be incredibly challenging. But hopefully the people, particularly in the front line, I hope that you guys will be able to look back on this experience with well-earned pride. So pivoting now to the impact on patients with rheumatic diseases. And when I'm talking about rheumatic diseases, I'm going to be focusing on those with systemic autoimmunity. Clearly, this doesn't account for people with, say, crystalline arthropathies or osteoarthritis, although there are certainly some significant impact on those patients. But the reason why I'm focusing on those with systemic autoimmunity is largely because of the milieu that they live in and also the treatments that are used. And so when you were talking about these type of patients, we constantly get 2 questions, and this is true virtually for every field. What are my chances of getting COVID? Will I get sick or will I die from this? And so ultimately, really what we're trying to assess at the end of the day really is going to be increased risk of poor outcomes. I already mentioned, we have systemic autoimmunity. There's a chronic inflammatory milieu that is associated with that. Inflammation does play a part in some of the manifestations of COVID-19 that are severe. many of these patients are immunosuppressives. What impact does that have on the outcomes, especially in terms of hospitalization or severe COVID-19? Comorbidities, how does that influence? We already know that general population comorbidities that influence vascular health, such as diabetes, hypertension, et cetera. Also lung disease impact outcomes. What are there other comorbidities also seen specifically in patients with rheumatic diseases? And of course, one of the saddest parts of the story has been the racial, ethnic, and socioeconomic disparities in terms of outcomes for COVID-19. All of these are also concerns for us. So the outline of my talk, there's so many topics I could have chosen from, but for the sake of time, really, I'm going to focus on a couple things. First is going to be the impact of COVID-19 on patients with rheumatic diseases, and we're going to be focusing on. I list risk factors, but really they're mostly associations at this point. Although some of these are likely going to be risk factors that are going to contribute to poor COVID-19 outcomes in patients with rheumatic diseases. I'm also going to focus on a story on patient behavior that has changed because of the issue with hydroxychloroquine, which was a campaign I got involved in very early on. If we have time at the end, I have about 10 minutes where I'll be talking about COVID-19 thrombotic disease. There are lessons here for rheumatologists that I want to be able to reiterate involving the interplay between the complement system, neutrophil activation, and endothelial cell injury. I'm not going to be talking about things like telehealth, although that's clearly important. I've also not going to be talking about repurposing immunosuppressive medications for COVID-19. I think that for a small subset of patients, that there's clear benefit to things like dexamethasone or IL-6 inhibition. But I think generally speaking, we're still waiting additional data. And then I'm also not going to be talking about things like the multisystem inflammatory syndrome that's largely seen in the pediatric population, nor cytokine storm. Cytokine storm is interesting because it receives so much play early on, but it's pretty clear that the prevalence of cytokine storm in severe COVID-19 is quite low, probably around 10%, maybe even lower. If you really want to read more about cytokine storm, David Feinbaum and Carl June had a really nice review published yesterday in the New England Journal of Medicine. Okay, so I'm going to start off with data, a data effort led by Ben Goldacre in a study called the UK Open Safely Study. So this study is interesting because it's the largest to date in linking, associating various conditions to COVID-19 deaths. Over 11,000 deaths were assessed in the NHS hospitals in the UK system. This is all linked to primary care data of 17 million adults. So this is, I think, close to about 40% of the UK population. And this used electronic health records repository data. So as you can see, this really established many of the associations. I think even in their study, they call them risk factors, which probably is also true regarding age, sex, obesity, and then ethnicity, all with worsening outcomes of death with COVID-19. On top of that, deprivation status, the more deprived you are, the more likely you are going to die from COVID-19 infection. And these are all fully adjusted numbers. And so you can see that many of these associate independent of one another. So they also looked at other comorbidities like diabetes, cancers, chronic kidney disease, or at least reduced GFR. And then the one thing that popped out in this particular study was the risk of having rheumatoid arthritis, lupus, or psoriasis as surrogates of systemic autoimmunity, where a statistically significant increase in COVID-19 deaths with an hazard ratio of 1.2 was observed. And so this opened up the idea whether or not systemic autoimmunity and its association with death, whether it was due to disease, was due to the treatment, or other factors. Just to note, other immunosuppressive conditions that are listed here is mostly largely due to HIV or primary immunodeficiencies. So another example at the population level where the risk of death or risk of worse outcomes was associated with rheumatic diseases was from the partner's healthcare experience. So this was led by Kristen De Silva, Jeffrey Sparks, and Zach Wallace. Some of you will know Jeff Sparks. He was a house staff here several years ago, trained at the Brigham. Now he's faculty of the Brigham doing exceptional RA epidemiologic research. So what they did was they took the patients that came to partners and matched based off of initial COVID-19 positive tests, because remember, as we've moved on with increasing experience with COVID-19, the outcomes have improved some. Sex, age, and other comparators, including or at least in the non-rheumatic disease, patients who were not on immunosuppression. When you look at the several models, including models that fully adjust for age, hypertension, coronary disease, and presence of lung disease, you can see that patients with rheumatic diseases had nearly a threefold increased odds ratios compared to those without rheumatic diseases. Again, suggesting that systemic autoimmunity is associated with worse COVID-19 outcomes. So early on, there was also recognition for the questions I had brought up earlier, and this led to the COVID-19 Global Rheumatology Alliance. I want to spend a few minutes discussing its origins because I think this is an amazing example of how rapid teams can be organized in executing important missions. So this is a provider, patient, and trainee-driven registry to better understand the relationship of COVID-19 with rheumatic diseases and therapies. Their website is here. Rima Saeed is our regional lead here. She's going to be your main liaison if you have any questions about our interaction with the COVID-19 GRA. So the really interesting thing about this organization is that everything started on Twitter, and it built incredibly rapidly. So Len Calabrese, who's a rheumatologist at the Cleveland Clinic, had been aware of efforts within the GI community, specifically the inflammatory bowel disease community, regarding a registry detailing outcomes of COVID-19 exposure in their patient subsets. So that registry is called Secure IBD. And from that, he said, why are we not doing this in rheumatology? Several other hours later, other rheumatologists globally, so Philip Robinson in Australia, Ginu Ziadani, who's chief of rheumatology at UCSF at the Zuckerberg Hospital, Philip Tsao at Johns Hopkins, all pitched in trying to understand, okay, how are we going to build this? What outcomes are important? A couple days later, the organization had started, and even within that 48-hour time period, we've already got the organization already got support from the American College of Rheumatology. The past president of the ACR, Ellen Gravellisi, said, "We are so impressed with this group's ability to organize so quickly and excited to see this initiative be realized. We're happy to support this important effort to help the global rheumatology community." So this is amazing speed that this entire effort got started with, and this is outlined by in this correspondence led by Jean Liu, who's part of the GRA. And this just gives you a timeline of how fast and also the mechanisms of how the communication occurred. So the purpose, identifying key stakeholders, identifying barriers, and creating solutions to make sure that this is feasible. All of this was done in the first 48 hours, all of it on Twitter. So Twitter has a lot of issues, but in many ways, it's also incredibly constructive, particularly with med ed, and also trying to galvanize and organize organizations such as this. From that, much of the work was then done on Slack. And I think what this highlights is that virtually none of this was done over email. So Slack and Discord really represent different ways to have effective team communication. And so these proprietary platforms really are the way our research team communicates. I think it's a great way to be able to organize things. So for those people who are not aware of Slack or Discord, take a look at that platform. It may really change the way how you interact with your teammates. So within 2 weeks, the registry was launched, and within 24 hours of launch, over 20 cases were submitted worldwide. So this, again, tells you how incredibly rapidly this effort was put together. So up to September 1st, you can see the total numbers of cases submitted by providers. So the global effort, which is largely the COVID-19 GRA, EULAR, which is the European effort, has their own separate registry, although data is shared between the two. And you can see that by September, over 4,600 cases have been submitted. So the initial data set that, or initial questions that patients had was, what are my chances of getting COVID-19? Unfortunately, registries cannot determine incidence, but there have been several studies, mostly done in Europe and in China, that have been examining incidence. And the one example I'm showing you here is an abstract from our recent American College of Rheumatology annual meeting, which is called Convergence, that happened a few weeks ago. And this is a systemic review of 15 observational studies, totaling nearly 12,000 patients. And you can see that overall the incidence of the prevalence of COVID-19 amongst those with rheumatic diseases was about 1.5%. The couple outliers here, this Freddy study from Brescia, Italy, which was one of the main epicenters, and also this study from Madrid, Spain, is also a mild outlier. But overall, the event rate calculated through the systemic review was 1.3%. So this is relatively similar to the rate of COVID-19 positivity in the general population in those areas during the time frame that the studies were accruing data. So really the bottom line is that those with rheumatic diseases aren't at any increased risk of infection, and the risk is really largely due to exposure. Now, when you switch over from looking from whether or not people are going to have an increased or no increased risk of getting COVID-19 to now looking at whether or not there are increased risk of developing severe outcomes or more advanced outcomes from COVID-19, the story changes quite a bit. So this is some of the initial data obtained from the COVID-19 Global Rheumatology Alliance that was published, I believe, in the late spring. And so what this examined was 600 cases from the first month of accrual of patients. About 46% of them were hospitalized, 9% of them died. You can see the disease breakdown here, and then also the comorbidities listed prevalence here. So there are several risk factors here that have been also observed in the general population, which is also true for those with rheumatic diseases. Those include age, comorbidities, hypertension, lung disease, diabetes, chronic kidney disease or end-stage renal disease. And then one of the things we're able to also look at here is going to be concomitant medication use. So here you can see at the bottom is that prednisone dose of greater than 10 milligrams a day was associated with a twofold higher odds ratio for hospitalization compared to those with less prednisone per day. This actually echoes a common theme in rheumatology, where I think we have been too complacent with the use of prednisone. And so there have been efforts both in lupus in particular, but also rheumatoid arthritis to try to limit the amount of prednisone people are on, largely because of the infections and also the damage that chronic prednisone use has. But again, here, this just confirms that some of the stories that we're getting from the immunologic perspective of COVID-19, that the idea that you suppress the immune system early in COVID-19 will lead to more severe outcomes later on. And so this is something that was, I think, highlighted here. What's interesting, though, too, is that there are some classes of drugs which actually decreased the risk of hospitalization. So biologic and traditional synthetic DMARD. So this includes all the biologic therapies, the parenteral therapies such as anti-TNFs, and also also JAK inhibitors were lumped together in this particular analysis. When you broke down the medicines that actually contributed greatest to the signals, it was actually anti-TNF therapies that was most associated with a reduction in hospitalization. So again, these are patients that are on baseline anti-TNF therapies, then contracted COVID-19. The explanation of which I cannot provide right now. I think this is, again, the beauty of these epidemiologic data is that they're hypothesis generating. So this is something that we're not really sure, the explanation for, or whether or not it's confounded by something else. But nevertheless, I think this is a really interesting observation. Another interesting observation is that generally speaking, most rheumatic diseases somehow, look like they mimic one another in terms of, the development of severe or more advanced manifestations of COVID-19. But one that is somewhat interesting is systemic lupus erythematosus. So the reasons for which are not clear to me. Again, this was not statistically significant, but this is likely more of a sample size issue in my mind. Updated analyses have not been provided quite yet by the GRA, but nevertheless, it does seem to indicate that a subset of systemic lupus erythematosus patients have increased susceptibility to requiring hospitalization. Again, the reasons for this are a little bit unclear. Generally speaking, lupus patients require more prednisone utilization, to be able to control their disease activity. But again, this is all controlled for prednisone. So this suggests that, again, systemic lupus erythematosus may associate independently with worsening outcomes of COVID-19 compared to other diseases. I think the one thing I want to also highlight, going back to glucocorticoids, is that you may think that glucocorticoids would be effective for COVID-19 largely because of the beneficial effects seen in the recovery trial. Again, I want to highlight that the timing of when you're going to give immunosuppression is, I think, critical in COVID-19. This is an argument that has been made by John Atkinson, Richard Hotchkiss, among others, to be able to say that we don't know when that inflection point is, but too much immunosuppression early is a bad thing. And so this is something that, again, we'll have a better understanding as time evolves. So let's focus a little bit more on the comorbidities, because some of these comorbidities are seen in higher proportion of patients with systemic autoimmunity. In fact, the leading cause of death in RA patients and lupus patients are going to be cardiovascular complications. So again, Christine De Silva, led an effort to be able to better understand the effects of comorbidities in patients with rheumatic diseases and COVID-19. So this is again from an abstract that was presented a few weeks ago. You can see in general that. So it's just a little bit background about the data set that she used. She leveraged the Trinext research network. So this is a multi-center research network with real-time electronic health record data across 35 healthcare organizations. So she was able to access data from over 52 million patients. And this is data from end of January through the beginning of June. And so what she was able to do was take patients with systemic autoimmune rheumatic diseases, and that's what SARD represents, who tested positive for COVID-19, and was able to exposure match them using age, sex, and then race and ethnicity. And so this is how she was able to get even numbers between the two cohorts. Just a little bit of background about the patients with rheumatic diseases. Again, similar to the GRA data, about 40% of them had rheumatoid arthritis, 20% had systemic lupus erythematosus. And then of note, 40% of these patients were on prednisone, although the dose was not mentioned within the abstract. But you can see here in those with COVID-19 with systemic autoimmune disease versus those without systemic autoimmune disease, there's an enrichment of the comorbidities that are known associations and risk factors for worse outcomes in for COVID-19, including hypertension, diabetes, lung disease, kidney disease, chronic kidney disease, and then cardiovascular issues. So again, these are things that have been documented, certainly in the general population, and it seems to be enriched within those with systemic autoimmunity. So then what she then asked next was, okay, I'm going to look at the various specific outcomes of COVID-19, specifically AKI, renal replacement therapy, or venous thrombus embolism, and see whether or not these risks are indeed enriched within this population. So again, if you match on age, sex, and race and ethnicity, you can see that all of them have a statistically significant association, anywhere between 1.7 to 1.8 in terms of a risk ratio. What she then did was say, okay, we know that the comorbidities are enriched within this population. So the question is whether or not do these comorbidities serve as causal intermediates. From a statistical perspective, you can just add this as a matched covariant. And here, what she saw was that the AKI and RRT, and to a modest extent, venous thromboembolisms, the risk ratios went down. Again, this doesn't necessarily causally show something, but this suggests that the comorbidities act as causal intermediates, potentially accentuating the risk of having a rheumatic disease for severe COVID-19 outcomes. And so this, so again, I think there's, whether it's additive or it's or stronger interaction is not really clear, but I think what's pretty obvious here is that if you have a patient with systemic autoimmunity and they have some of these comorbidities, you really are substantially increasing the likelihood of them having some sort of a severe COVID-19 manifestation. So what we're going to do here is switch over to disparities. And so unfortunately, the story within patients with rheumatic diseases mimic the story that's seen in the general population, that generally those with who experience socioeconomic disparities are going to have worse outcomes. So this is, again, data from the Global Rheumatology Alliance. This is now data comprising over 1,300 cases that have been reported through essentially the end of August. And what's being reported here are odds ratios, and this is all adjusted for these covariants here. And so the outcomes that looked at were hospitalization, ventilator support, and also death. And with white being the reference, so this will give you, an odds ratio of 1, you can see that for hospitalization, Black, Latinx, Asian, all had a statistically significant increase in the odds ratio for hospitalization. For ventilatory support, this odds ratio of 3.25 was observed within the Latinx population. But as you can see, also the odds ratios were positive for the other minorities, populations, but they were not statistically significant. Death, none of these were statistically significant, but still the odds ratio was a little bit positive. This may represent some sample size issues, but nevertheless, I think this does continue to confirm that outcome disparities do occur in patients with rheumatic diseases with regard to COVID-19, and it tends to be experienced with those of non-white background. A more specific examination of this was done by Ashira Blazer, who's at NYU Langone. And what she wanted to take a look at was to have more granular, a more granular idea of whether or not living in specific neighborhoods increased the risk of having COVID-19 in those with systemic autoimmune diseases. So she used this index called the ADI, the Area Deprivation Index. This is the measure of socioeconomic distress locations. And this is really done by mapping to specific locations using geocoding. And so you can see here of all the patients that were put into this registry that's called the WARCALL, or the web-based assessment of autoimmune, immune-mediated, and rheumatic diseases during COVID-19 pandemic. You can see that this is the distribution of the patients that were captured through that registry. The lower the ADI, the less deprivation occurs. The higher the ADI, the more deprivation occurs. So you can see this is all color-coded with the 5 boroughs of New York City, and the majority of them live within, of course, the 50th percentile here. So just I'm going to give you a little bit of an idea of the numbers here. Most of the numbers that we're going to be talking about for this study is going to be within the high 90s to the low 120s. So it's going to be somewhere between like the 30th to the 80th percentile. So, okay, so then what she did was said, okay, we're going to look at whether or not those with certain neighborhood characteristics that associate with deprivation have higher rates of COVID-19. And so here what she did was did a unbiased hierarchical cluster analysis to associate ADI with COVID-19 testing outcomes. So here's a circle cluster dendrogram showing in the outer rim COVID testing results. So those in green were positive, those in pink were negative. And then these dendrograms have identified, again, in an unbiased way, 4 groups. Groups 1, 2, and 3, 4. Groups 1 and 4 had the highest ADI. In other words, they had the highest deprivation scores. And not surprisingly, and unfortunately, the highest proportion of COVID positive testing occurred within groups 1 and 4. So again, this highlights that the burden of COVID-19 was experienced most heavily within neighborhoods that had the highest deprivation. And again, this is all within rheumatic diseases. When you now look at an outcome such as hospitalization, this also was true. So you can see here that there are, again, in green are going to be patients who required hospitalization, and pink here are patients who did not require hospitalization. You can see that, again, there are four dendrograms, four groups that were identified. So group 1 here had the highest, and group 2 had the highest ADI scores. And you can see that for group 1, the ADI score here of 33% associated, 33% of these patients required hospitalization. Interestingly, group 2, which has had the highest ADI, which is in green here, had a 20% hospitalization rate, which is similar to that was found with group 3. Group 4, which had the lowest ADI score, in other words, had the least amount of deprivation, had the lowest hospitalization rates. So again, this is a really unfortunate and sad story because the burden of COVID-19 really is concentrated amongst those with highest deprivation. And again, the reasons for this are going to be multifactorial and complicated to unwind. But this is true with rheumatic diseases, and data that I'm not showing here. Shira shows that this is also independently associated with worse outcomes, even adjusting for comorbidities and even race. Okay, so I'm going to wrap up this particular section examining the risk of death and associated with rheumatic diseases. And so again, this is data that was presented in abstract format at our ACR conference. And so this now looks at 3,700 cases up to July 1st. Odds ratios are being reported here. And again, they're adjusted for all of these covariants here. And so this is divided up by all patients, inflammatory joint diseases. Rheumatoid arthritis was looked at independently, and also connective tissue disease. The vast majority of these are going to be lupus. So again, in terms of higher odds ratios of death due to COVID-19, age, it was a major factor, male sex, particularly for connective tissue diseases, and then also having higher disease activity. All of these are associated with increased risk of death due to COVID-19. I think what's new for rheumatologists here is this piece of information about disease activity. So this highlights the need to control disease activity as efficiently as possible in order to lower the risk of having poor outcomes in this patient population. But what's more interesting, I think, is going to be this analysis. And this is something I'm still trying to process. They then looked at the various types of medicines that we give to our rheumatic disease patients and tried to understand the risk of death associated with that. So methotrexate, which is one of our traditional DMARDs, is used as the reference. So that's going to be your odds ratio of 1 here. So everything's being compared to that. So the groups that are associated with that is going to be first glucocorticoids. This is confirmation of prior data, although the effect was really mostly seen in the connective tissue disease, i.e. lupus. But what's also interesting is that those on no medication all had increased odds ratios of death if they contracted COVID-19. And so, this is at the risk of overinterpretation. But again, I think this suggests that having an autoimmune disease, and especially poorly controlled autoimmune disease, probably serves as a risk factor as opposed to just a mere association. Because again, disease activity in these analyses were controlled for. So that's something, again, to highlight to our rheumatologists here to really work on trying to find strategies to improve their disease activity. But the type of medicine used to control their disease activity is going to be important. In a signal that I cannot explain, sulfasalazine is also associated with higher odds ratios of death. So the sulfasalazine is an interesting drug. Its full mechanism of action is still not clear, but it has anti-inflammatory effects, largely mediated by its metabolism to mesalamine, which is a salicylic acid derivative. It also has nice in vitro data attenuating NF-kappa B activity, which is going to then attenuate inflammation. But other than that, it's not really clear what else it does to the body. And so you can see here that in general, there's a relatively robust odds ratio here of increased odds ratio of death associated with sulfasalazine use. And the other one, which probably has a more reasonable explanation, is rituximab. So remember, rituximab is a B-cell depleting agent, and this actually has the highest signal of all of the medicines that were analyzed for in terms of association with death. The earlier analysis that I showed before from the GRA regarding hospitalization, rituximab did not have a signal, but at least with death, their signal is pretty apparent. I think the simplest explanation would be that you're just preventing the development of protective antibodies. You remember rituximab depletes most B cells, and particularly ones that are going to be important in terms of differentiation into antibody-secreting cells downstream during acute infections. So, and the effect of rituximab can last for months. We don't redose this medicine until every 6 or 12 months. So you can see how durable this type of medicine is in terms of B cell depletion. So, it also stands to reason that poor antibody responses have been observed in rituximab treated patients to flu vaccination. And in fact, again, if you're going to vaccinate someone with the flu vaccine, people who are on rituximab, they actually recommend you wait 6 months before administering the vaccine. So the timing of rituximab in the fall is critical in terms of make sure that you can get the flu vaccine prior to the administration of rituximab. So again, this I think makes more sense than some of the other findings here, particularly sulfasalazine. Again, does this highlight whether or not immunosuppression as a whole is dangerous? It doesn't necessarily demonstrate that. But at the same time, I think there are some specific variables here that may influence whether or not a specific DMARD or biologic agent is going to be more hazardous to patients. All right, so with that, I'm going to take an interim kind of little break here and give you some conclusions. And again, this is largely for the rheumatologists in the audience. I think it's pretty clear that patients with rheumatic diseases are at increased risk of developing worse COVID-19 outcomes. There are several lines of data that suggest that. Outcome disparities are observed in rheumatic diseases, very similar to the general population. I think our role as healthcare providers, we need to continue to advocate, and I think I'm going to highlight this in the hydroxychloroquine story. Certain medications may further increase that risk. I think glucocorticoids is a pretty solid bet. Rituximab, I think maybe there too. The goal for us, though, for the patients, we really have to figure out better ways and more aggressive strategies to control disease activity while minimizing glucocorticoid use. This seems so obvious, and of course, this is really hard to achieve. And so this is, again, this is the kind of the challenges that we face as rheumatologists with these type of diseases. In terms of additional data, I think risks with specific diseases such as lupus is going to be something that we need to take a better look at. TNF inhibition in terms of hospitalization, remember the sulfasalazine and rituximab increased death. I think confirmation from additional cohorts would be important there. And then, of course, the patient experience. There's several studies that were presented at ACR looking at patient-reported outcomes, and generally they are worse, not surprisingly. But I'm going to give you a very specific story using hydroxychloroquine as an example. I was not going to talk about this, but 2 weeks ago, Ashish Jha, who is the dean of the Brown University School of Public Health, was asked to testify at a Senate hearing and about hydroxychloroquine. This is 2 weeks ago. I mean, as far as all of us are concerned, this story died during the summer. But again, this is really, it really threw me a little bit. I was really confused by this because, this is, again, highlights the politicization of the story of hydroxychloroquine. So I want to be able to give you just a little bit of background about how the story got to be, because I think it's an interesting perspective about, how information or misinformation occurs, and then how it impacted patients, particularly with lupus, rheumatoid arthritis, and Sjogren's syndrome, where hydroxychloroquine is used quite a bit. Again, there was in vitro data that suggested that hydroxychloroquine might be able to attenuate, or had an antiviral effect. Of course, these are done in vero cells. So for the virologist, these are a common cell line that's used and have very unusual immune properties. For example, they can't make their own interferons, which is a very potent antiviral cytokine. But nevertheless, using EC studies, the EC50 of 1 micromolar was identified to get the EC50. But again, if you're going to attenuate just 50%, that may not be sufficient. So if you look at EC90s or even 100% clearance in vitro, you're going to require concentrations of 10 to 20 micromolar. This gives you blood concentrations somewhere between 3 to almost 7 micrograms per mil. And the real question is this even achievable in the blood? For lupus patients who are on max dose of hydroxychloroquine, typically we see blood levels of about 1 microgram per mil. So you can see how much higher the dosing is going to be needed in order to achieve those levels within the blood. Nevertheless, this was propagated throughout social media. So this is now the bad part of Twitter. So somehow James Todoro started advocating for this. And again, this was really, the origins of this story really was in Silicon Valley. So Todoro was a ophthalmologist in Michigan. He doesn't practice anymore, and then started this investment fund called Blockchain Capital in 2018. So he, along with a friend of his, Gregory Regano, who's a lawyer, really started putting together on Google Docs essentially, weak position statements advocating for the use of hydroxychloroquine in COVID-19. And then Elon Musk somehow, came into this, because they're within the same circle, and also tweeted this. So soon after that came the first study, which is an amazingly poor study, which I'm going to call a pseudo-virologist in Marseille, France, named Didier Raoult. So this is the first clinical data that suggested that hydroxychloroquine may be effective in patients with COVID-19. He called it a clinical trial. This is really a single center case series. They used hydroxychloroquine at 600 total milligrams a day for 10 days. The control group were patients who refused hydroxychloroquine, so they never were consented. And also patients who were from other clinical centers, and because the study was only done in Marseille, and so they use those as controls too. So now you introduce a ton of confounders, including treatment confounding. The endpoint is a non-clinical endpoint. This nasopharyngeal virologic clearance at day 6. The results that they published said that they had 26 patients that were treated, 16 patients in control, 6 patients were lost to follow-up, and then we'll come back to this in a second. 70% of the patients cleared virus who were treated with hydroxychloroquine versus 12.5% in the control. And all patients with azithromycin, which I think was only like 6 or 7 patients of the combination hydroxychloroquine and azithromycin, were, as the paper used the word, cured. In other words, they're just PCR negative. The limitations of the study are so substantial that it really renders the study completely irrelevant. Again, there's a non-clinical endpoint. The control group is poorly conceived and unethical, essentially. The different centers of the control population leads to the possibility of different treatment protocols. Remember, this was done very early, in February and March. Patients lost to follow-up in the treatment arm were also something you need to pay attention to. The reason why these were lost to follow-up is because they were unable to meet the primary endpoint of getting a nasopharyngeal swab at day 6. Now, the reasons for this are interesting. 3 patients worsened. They were transferred to the ICU. Apparently, either they were unable to get these samples when they're in the ICU, or they did not report on the samples of these patients that went to the ICU. 1 withdrew due to side effects of hydroxychloroquine. 1 patient died, and then maybe 1 positive outcome potentially that 1 patient got discharged home. Based off of these data, they made this statement: for ethical reasons and because our first results are so significant and evident, we decided to share our findings with the medical community given the urgent need for an effective drug against SARS-CoV-2 in the current pandemic context. This is a gross overstatement of conclusions. And of note, peer review most likely did not happen. The preprint came out, I believe, on March 20th. And when the published version came out several days later, it was completely unchanged, word for word. Again, this then got propagated. Breitbart, in their, what they do, then started advocating this as a drug. And then, of course, on March 21st, Donald Trump then tweeted this, which led to a massive increase in the interest of using hydroxychloroquine. So this is data obtained from Michael Putman and Jean Liu, who basically just did a Google Trends a search, be able to look for chloroquine, hydroxychloroquine, also hydroxychloroquine shortage. And you can see the spike at the publication date of the preprint from DDA's group, and then the press conference, and then the tweet by Donald Trump, you can see an exponential rise in interest. This led to a surge in prescriptions being made for hydroxychloroquine. Now, you have to remember that the supply chain for hydroxychloroquine is very limited. The diseases that it treats is seen in about 1 to 2% of the US population and global population. So the supply chain really is only limited to that 1 or 2% of the population. Now you have a 45-fold increase in prescriptions. Clearly, because the supply chain was unable to react quickly in time, and along with hoarding by healthcare providers, pharmacies, hospitals, and governments. Remember, the US government hoarded 63 million doses of hydroxychloroquine during the pandemic. There were substantial concerns about shortages for our patients. And the reason why this is important, I'm going to highlight data from lupus, is because hydroxychloroquine is a mainstay and cornerstone drug for lupus treatment. It is the only treatment that has been demonstrated to have a survival benefit. So this is data from the Latin America and South America lupus cohort, where they show that there is a 3.4 or 3.1 fold increase in survival when people are on hydroxychloroquine versus not on hydroxychloroquine. On top of that, hydroxychloroquine cessation does lead to flares. So this is an interesting study done in the early 90s, which probably can't get done today. They basically took clinically stable lupus patients and then gave them either a placebo, which meant it was going to be hydroxychloroquine withdrawal, or hydroxychloroquine. And for those people who had a flare, it was the flare rate increased 2.5 times higher in those with hydroxychloroquine withdrawal. And again, remember, this was a blinded randomized study. And then in terms of severe exacerbations or severe flares, in those who had hydroxychloroquine withdrawn, they found a 6.1 times higher rate of a severe flare. What's I think a little bit scary about this too is that the flares occurred as early as 2 weeks after cessation of hydroxychloroquine. So people started looking at this. So globally, from the patient-reported outcomes, or patient-reported surveys from the Global Rheumatology Alliance, which encompassed about 3,800 respondents. Generally speaking, the shortages were relatively low, surprisingly, 6.2%, although it tend to be very specific for regions. In Americas, again, largely demonstrated a low shortage issue, along with Europe. The parts of Asia and Africa had substantial issues with shortages. Nevertheless, despite this, patient perceived worsening of disease activity increased. So this is a scale from 0 to 10, and went from those who had hydroxychloroquine of a score of 4.2 to a score of 6.4 for those who were unable to get hydroxychloroquine. In the hospital special surgery, they also looked at reasons for whether or not why antimalarials were stopped or reduced. And so, in terms of patient-driven reduction or cessation, most of the decreases were occurring because the drug was missing in that particular area where that patient was. And then, interestingly, about half the patients stopped the medicines. Of those who stopped the medicines, about half of them listed that it was not effective for COVID-19 treatment. So again, this is I think a failure of how we did not instruct our patients enough about the benefit of hydroxychloroquine for their lupus. And even though they did not have COVID-19, they would think they were taking it mostly to prevent COVID-19. So they actually stopped the medicine on their own, even though they would be taking it for their lupus. So again, this is another failure of the communication stream between what's been reported and then what's reality. So Peter Korsten in Göttingen, Germany, also did a survey looking at their patient experiences with hydroxychloroquine. Many of them were concerned that they were unable to secure it, but only a handful of them had to reduce it, or only a handful of them actively reduced it. But you can see within their cohort in Germany, about 50% of them required some sort of intervention to maintain their hydroxychloroquine supply. I can tell you anecdotally, we've experienced the same issues here at WashU, where the majority of our patients require phone calls from us to be able to find new sources of hydroxychloroquine because our pharmacy ran out of it, particularly within the late March and April time period. So we did a great deal of work trying to dispel the misinformation and disinformation regarding hydroxychloroquine. And so one thing I wanted to highlight here is that we have written several opinion pieces and reviews regarding this topic. One of these reviews is the references here, and actually a QR code to that review is listed on the top here, where Ariella Kohler-Riley, who is an MSTP student, probably one of the best medical illustrators I've ever met, helped us develop this pendulum figure, which essentially what goes through the timeline of key events, including media and data, and then media mentions here on the right side. And essentially the summary here is that the initial pendulum went from hydroxychloroquine as a miracle drug to hydroxychloroquine is deadly, due to the cardiac toxicity issues, to ending up where hydroxychloroquine is not effective. Essentially, the pendulum continues to want to switch over to miracle drug, which is, again, amazing to me. This is a dense figure, and so our patients actually asked for a more streamlined figure, which is going to be, you can download that with this particular QR code below here under Streamline. And again, this is going to be listed with these slides will be available after the talk. So given the time, I am going to skip this last section, although I do want to mention that the theme of complement neutrophils and thrombosis is common among several other diseases, particularly endotheliopathies, antiphospholipid syndrome, atypical HUS, likely scleroderma renal crisis, preeclampsia. We think, and this is me being Anuja Java, John Atkinson, Kathy Liszewski, me, Rich Kulkarni, all think that there's a likely strong contribution of this particular triad to the hypercoagulable state that's seen in patients with severe COVID-19. Rich Kulkarni is the site PI for complement inhibition clinical trials here at WashU, and so you can, I'm going to volunteer him to answer any questions regarding the status of those trials. Okay, so I'm going to wrap up here. Again, to reiterate, patients with rheumatic disease are at increased risk of developing worse COVID-19 outcomes. This is potentiated in my mind by comorbidities. There are certain medications that may also potentiate this. And then clearly there are disparities that are associating with worse outcomes. A ton really is not known, though. Impact on patient quality of life, again, we know it's worsening. I think there's going to be increasing data over the next several months, being able to demonstrate at a granular level how much worse it is and what aspects of their quality of life domains that are worsening. The impact and durability of telehealth, I think this has been beneficial for a lot of my patients. The idea that I can talk to them virtually in their kitchen or living room is something that they find a lot of comfort in. You obviously lose the physical exam, which is problematic, and it's not as easy to be able to obtain labs. So again, how this particular ecosystem evolves in the future is going to be an important topic. The biologic influence of immunosuppressants that alter COVID-19 outcomes for good or bad is also still unclear. I want to highlight this correspondence from the Brigham Group. This is actually a patient that was reported a few weeks ago of Jeffrey Sparks. And essentially, this was a patient with severe catastrophic antiphospholipid syndrome on high-dose prednisone, eculizumab, which is a complement inhibitor, to C5, cyclophosphamide, who had a persistent COVID-19 infection over 153 days, I believe, unfortunately passed away, not because of thrombosis, interestingly enough, but likely due to COVID-19 and other secondary infections. The highlight of this case study actually was to show the evolution of the spike protein and receptor binding domain in COVID-19 over the 153 days. And it's a very interesting case report. So again, it was sometime last month in New England Journal of Medicine. But I think this just gives you another idea and kind of on one level about the impact of the immunosuppressives and what limits of immunosuppressions do we have in order to maintain reasonable outcomes, both for rheumatic disease, but also for COVID-19. And then the last thing is going to be vaccines. We're all the vaccine studies really have excluded immunosuppressed people. So the questions are going to be whether or not these vaccines are going to be effective or not. And of course, there's going to be safety considerations. These are RNA vaccines, and this is actually a particular concern to lupus patients who have exquisite sensitivity to nuclear antigens, DNA, RNA, DNA binding proteins, and RNA binding proteins. In both humans and also in animal models, if you deliver RNA, these patients tend to get worse. They will flare. And so this is going to be an interesting sub-question whether or not these RNA-based vaccines, which are essentially in little nanoparticles, are going to be associated with worse outcomes in lupus patients. Nevertheless, we still don't know whether or not effective responses would be mounted in these type of patients. And so actually about 18 hours ago, I got an email from Matt Chorba regarding whether or not there's any data on this. And so what we are going to try to do in the next week or so is to organize an effort. So it'll be Matt Chorba and Parakal Deepak from GI and IBD, and then myself and Michael Paley in rheumatology, along with the help of Ali El-Abadi, who has expertise in antibody vaccine responses, to be able to better study the impact of immunosuppression with COVID-19 vaccination. And so this is something, again, we will be putting together, and hopefully we'll be able to send out some announcements soon after our organizational meetings. Okay, with that, I'm done. This has been, it's a little confusing because we're dealing with an incomplete data set, but I think there are some substantial concerns in rheumatology about the impact of our diseases and medicines with COVID-19. But again, the story continues to be written, and this talk 6 months from now may look very different also. So with that, I want to thank everyone for their attention, and I'll be more than happy to take any questions.
Thank you so much, Dr. Kim. Everyone can feel free to use the Q&A function or the chat function to send any questions to Dr. Kim in the couple minutes we have left. I loved your talk, Dr. Kim. I think it was fascinating, especially now with the surge, happening throughout the country and the world. I think a lot more patients are going to be included in these data banks as well. My question is kind of leading to the vaccine. How do you plan on counseling your patients with lupus about this vaccine, which will likely be available to them earlier than, other members of their family? I'm assuming you've gotten some questions already. What's your strategy to talk to your patients about this?
I mean, transparency obviously is going to be important. We have no idea. And so we anticipate if we're able to get this effort off the ground, which I think we will, we are going to have issues with recruitment because obviously we can't, force the vaccine onto them. And we're not really doing an interventional type of trial here. We're not really equipped to do that. So I think that we don't know very much about it. And while we think it's probably largely safe, this is, we're kind of used to this within rheumatology. We're obviously dealing with uncommon diseases seen in single-digit prevalence and lower. And so a lot of things that apply to people with diabetes or hypertension are not known, the effects are not known in our population. So to a certain extent, a lot of our patients are actually very used to listening to us saying, we're not sure. All right. And so again, the counseling then becomes really more about ensuring that their level of risk adverseness, trying to gauge that and making the best decision for them. If they're really gung-ho and getting the vaccine, I'm certainly not going to stop them as long as they understand that the risks are unquantified and and basically undescribed.
And to follow that up a little bit, in your perspective, if a patient wasn't controlled on, in regards to their autoimmune disease at that moment, would you recommend that they go ahead and pursue vaccination? Or I know I'm asking a lot of hypothetical questions here.
Right.
How would you kind of approach that with this data that you presented?
Yeah, so it's interesting. Okay, so my gut would say, probably a bad idea. In general, I think even with flu vaccinations, we don't typically give them to my patients who are flaring with their lupus. We tend to wait until they have disease quiescence. So this may also be true, but I've also been burned by my gut a lot. And most of the times my first reaction and instinct is wrong. So take that answer with that grain of salt.
Thank you for that. I see one question has come in here. Reports of post-COVID syndrome have speculated that this is related to an enhanced long-term immune response to the initial illness. Are there any data to suggest that the vaccine could possibly enhance this immune response?
I have no idea. It's a good question, but I am definitely the wrong person to answer that question. I'm sorry, I don't know the answer to that.
Yeah. I think that, I agree. I think that this talk in 6 months, 1 year, it's just going to continue to evolve, and we'll have a lot more information at
Right.
hand.
Right.
Thank you so much, Dr. Kim. I will go ahead and share my screen to give people the QR codes. And if there's any other questions that come through, I can make sure I forward them along to Dr. Kim
Okay,
as
great.
well.
Thank you so
Thank
much.
you.